Hello. Hello. All right. I think this is too loud. Okay. So welcome everybody. This is great to have you here. I'm just going to give a brief introduction. So it is really a true pleasure to introduce you or to welcome and I guess to officially talk about the 9th Clinical Research PM&R Expo. We have been doing this, as the title says, 9 years now, and I think we have been growing very nicely. I really like the spirit of this event, where we have a representation of research, QI activities, clinical activities, all displayed. This is very also inclusive because we invite people from all the disciplines. Basically, all rehab staff is here today. The number of posters this year is a little bit less than last year, but I think the quality of the posters is a little bit better. So it's okay. We cannot, quality for quantity is always a good relationship. So thank you everybody for coming today and participating, having posters and so on. And with these, I like to give a strong thank you, maybe a round of applause for Michelle Sivach and Kevin McLaughlin for organizing this event. And if they did a good job, we have food afterwards. We'll see. Yes. They're saying yes, but I don't know. Maybe overconfident. I also want to say thank you to few folks who have reviewed the posters and the abstract presentation. So this is Megan Bayer, Ryan Romick, Soumya Campbell, who peruse all your abstracts and so on. So that's also very important work. And Preeti Raghavan, who is, as you know, the new vice chair for research in the department, who also helped coordinate all the events of today. And so I just didn't do much at all. I'm just taking the credit of coming here and introducing the event. But I'm very happy actually to introduce a very good friend of mine. This is Dr. Carmen Terzic. So it's honestly, it's a true pleasure and a privilege and an honor to be introducing her here today and to have her here visiting for a couple of days. Carmen has been going around and talking to different folks. And I heard that she has been impressed with the things that she's been talking about and the things that we've been doing, which is also nice and rewarding. So let me tell you a little bit about Carmen. Dr. Terzic is the chair of the PM&R department and the associate medical director for cardiovascular rehabilitation at Mayo Clinic. She's a physician, she's a clinician scientist, and she specializes in cardiovascular rehabilitation and neuromuscular rehabilitation. As a scientist, Carmen has done a very impressive amount of work supported by NIH and other agencies, focused on developing regenerative medicine and stem cell-based cardiac repair, as well as optimizing the properties of the cardiac heart and the cardiac commitment, as well as studying the role of nuclear transport during stem cell differentiation into cardiomyocytes. I mean, the work on regenerative medicine that Carmen has been doing has been instrumental in pushing this field. She's going to talk a lot about the heart today, but I think that a lot of the lessons learned are also being translated to the musculoskeletal system. So it's very, very important for the things that we do in rehabilitation and the future of rehab. So Carmen did her medical school in Venezuela. So she has an accent like me, maybe a little less than me. And of course, we have the Latino connection there. If you leave us alone, we start speaking Spanish and we don't stop. She did her Ph.D. and residency in PM&R in Mayo Clinic, and she remained in Mayo Clinic since then. So with that, Carmen, thank you again for coming here, spending a couple of days with us, and sharing the science and knowledge that you have acquired over the years. Thank you.
Thank you very much, and I want to say that it's a privilege and an honor to be here with all of you. I had a wonderful day yesterday meeting with some of you, leaders and therapists and students, residents. It was really very refreshing, energizing. I was very excited to listen listening and learning of all the wonderful things that you are doing, and I already have some plan to come back or to send some of my staff here to learn more, as you are doing wonderful things. So thank you very much, Pablo, and all of you for giving me this opportunity. And as Pablo said, I speak with accent, but because you are now at this point used to Latin accent, so I don't think that you will have any problem to understand me. I hope so. I don't have any disclosure, and this is a picture of the outpatient setting at the Mayo Clinic. So Mayo Clinic, and I'm going to mention this because it will be important for some of the data, some of the slides that I'm going to show, but Mayo Clinic is a big center. We have 60,000 employees. It's the #1 private employer in the state of Minnesota, the largest one. And the town is only 105,000 people. So you can imagine that basically Rochester is Mayo, Mayo is Rochester, is a combination. So this has a lot of negative connotation, but being a big medical center in a cornfield, as we say, in the middle of the United States, or the middle of nowhere, but also give us the opportunity, as we are the only medical center that provide medical service to the town, but also the town surrounded until Minneapolis. So we have a very robust epidemiological data collection, a database with basically every single individual in town. We have information about their health care, social status, everything. So that give us this opportunity. This is one of the positive aspects to be the lonely medical center in the area. So some of the data that I'm going to show is not just because I'm showing Mayo data and one that you feel that is pretentious, is because we have so much information about our cardiac rehabilitation, because basically everybody to go into the hospital with a cardiac event is from the area, and we keep following them forever. So we have a very robust data. So why we were going to talk about that, and I would like to convince you at the end of the conversation that all the principles that we can apply in our cardiac rehabilitation program also can be applied to every single disease and every single primary and secondary prevention. And this is just an example of what we call the ecology of cardiovascular prevention, all the impact in other disease and all the connection. Coronary artery disease affecting stroke. Stroke may produce coronary artery disease. I mean, those are vascular diseases, so they have the same risk factor. Atrial fibrillation involving those, peripheral artery disease, heart failure, diabetes playing an important role in all of them. So as you see, it's a huge combination on many other diseases that we put it together into the vascular concept. So prevention is key. I always say that when we treat somebody with diabetes or a stroke or a heart attack, it's a failure of medicine. We should be preventing. So starting with the patient. So the patient has to learn how to live under the umbrella of good cardiovascular health. So what do we need to do? Exercise, good diet, good nutrition. I don't call it diet, but good nutrition. And be active and stop smoking or no smoking. So those are the aspects that the patient should do, that we should tell the patient to do, so it's their responsibility. If we do that, so we hopefully will have an ideal level of 3 key factors that play an important role in multiple vascular disease, which is good fasting blood glucose, LDL, and blood pressure under control. But if some of these are out of control there's other factor, genetic, for example, age, so the role of the physician in controlling that play important role. So together a combination between patient and physician, but also community. I mean, I'm going to bring that, as I said, I have a wonderful time yesterday, and I had the opportunity to spend almost 2 hours with the residents, and many of you, I think, are here. And we have a wonderful discussion about community prevention, and they gave me some ideas about some new slide that I should be presenting today. So I brought this, which is it has a slide showing the importance of where do you live. So many studies have shown that the life expectancy difference in the same city is around 15 to 20 years. So you may live in Baltimore, and depend if you live in the west or in the east of Baltimore. I heard that the east of Baltimore is not as good as the other areas, so the life expectancy can actually vary by 15, 20 years. So we need to be sure and to understand also not only genetic factor, personal factor, but also racial, ethnic, socioeconomic factor, and environmental factor that play an important role. And there is something that the Center for Disease Control called death by zip code. I don't know if you have heard about that. But, and they have developed what they call the Distress Community Index, and those are the aspect of this index that you can see there: unemployment, education level, so they take a consideration in the community, all these factors, and they can develop a score that goes from 0 no distress to 100 severe distress. And community with an index more than 75, they are considered on danger. And those are the community that the life expectancy decreased by 15, 20 years. So it's important also to incorporate this injury and evaluation and the discussion with the patient and how we can help. So, and specifically for cardiovascular disease, there is a nice paper that was just published in this year showing that a patient that coming from this community that have an index factor more than 75, they are increased risk for adverse event and death after coronary artery bypass. So the mortality is higher. So how cardiovascular rehabilitation principle can help us to control vascular diseases, I mean, not only cardiovascular disease, but other vascular conditions. So what is the best, and I will bring this question, I had this question to the students, so now I bring it to the rest of you. What is the best medicine that we have for every single disease? Exercise, yes. So, and I wanted to bring, and I forgot, but what we did in the cardiac rehab is we have a bottle, like a medicine bottle, and we give it to the patient at the end of the appointment, and they say, what is that? What medication is that? It's empty. Read it, and it's an exercise prescription, but we give it in a bottle. Exactly, look, exactly. So they start laughing like, we did, and they got it. So that's, this is the best medicine. And what happened when patients are involved in cardiac rehab, and we will see that, is that for patients with cardiovascular disease, the most well-established model for healthy lifestyle intervention in the current healthcare model system is cardiovascular rehab. We see these patients in a repetitive way. We tell them the importance of exercise, lifestyle change. So after 36 sessions, this is the session that we have in the cardiac rehab program, they got it. In 36 times telling the same thing, you got it. So this is, as today, the most successful intervention. So we should learn from this and extrapolate to other conditions. So what is cardiac rehab? And it's a multidisciplinary approach. So that is very important. It's not only one group of individuals of medical specialty, it's a multidisciplinary. In our group, we have, and many other centers have the same thing, we have physical therapists, PM&R physician, cardiologists, endocrinologists, psychologists, expert on sleep, so pulmonologists, and also psychology expert on tobacco cessation. So it's a really multidisciplinary, nurses and exercise physiology play an important role. And we are focusing on therapeutic education. So this is very important because people in general believe or think that cardiac rehabilitation is only exercise. Exercise like 60% of the program. And I will say that some studies show that the positive effect that we get from cardiac rehab is due probably 60% or 70% due to the exercise, but the other is due to the extensive education. So we take opportunity to teach, and then risk factor management, all risk factor for vascular condition and others, optimization of functional status and mental health, and we will see some data talking about how important it is, and also regular patient evaluation, monitoring, support patient, and be sure that they are in compliance and adherence to the recommendation. So that's what makes it this model, multidisciplinary and attacking the problem in different levels, is what makes it successful. And the next group of slide talking about we can spend hours and hours talking about the data that support this, so I'm going to be punctual, but some of the positive effect that we see in multiple organs. So cardiac rehabilitation, we see improvement in symptoms of exertion, dyspnea, fatigue, claudication. This is pretty clear the patient improved that, autonomic tone, cardiovascular fitness, 10 to 40% increase in aerobic capacity in patients that participated, and increasing the metabolic equivalent 35%. And why this is important, when we just mentioned that exercise is the best medicine, we know that the people that are involved in physical activities, even if it's not going to the gym 2 or 3 hours killing themselves, but in leisure time physical activities, increase the mortality, myocardial infarction mortality for cardiovascular condition by approximately 35–50%. And this is data from 78, so we know that from a long time ago. And if we keep going in time, so there is this study, the aerobic center study, very comprehensive. They did almost 13,000 participants, men and women. This was published, I think, in the 80s, 89. And this study showed that regardless of the gender, there is a very direct and strong correlation between cardiopulmonary fitness level and death. So as you can see there, in individual with low cardiopulmonary fitness level, men or women, when you compare with high, the rate of death, it's a significant decrease, very huge impact. What are the effects of physiological effect of the cardiac rehab in general? Improve endothelial function, so patients that participate in cardiac rehab have improvement of endothelial function, antithrombotic effect, peripheral adaptation, skeletal muscle, decreased arterial stiffness, and endothelial-dependent vasodilation, say endothelial function. So those are a very specific functional and physiological effect in the cardiovascular system. Improve autonomic function, and lipid and inflammation. So individuals that participate have improvement on all this lipid profile, as you can see there. And the greater improvements are observed in patients that have abnormal level, but even people with normal level, there is further improvement. We have also change in C-reactive protein. So C-reactive protein is a marker of inflammation in the body, and we know now that coronary artery disease is an inflammatory disease as well. So there is a strong correlation of the level of CR protein and death or advance of coronary artery disease. So it has been used as a marker for prevention, secondary prevention, and help us to define medication or not, the intensity of the medication. So we know that people that participate in cardiac rehab, as you can see over there, there is a significant decrease in C-reactive protein. Cardiovascular risk factors. So we talk about specific physiological change in the cardiovascular system, and lipid and inflammatory, but what happens in other control of other diseases that play an important role in cardiovascular disease. So diabetes, insulin resistance improve, blood pressure improve in patients that participate in the program, metabolic syndrome, reduction of percent of fat, and promote weight loss and weight maintenance. And this is a data from 377 patients, 1 year participation. This is more or less the average of patients that we have in our program a year. And we see that the weight loss, intentional with diet and exercise, was significant associated with decrease of major cardiovascular events in patients that participate in the program. Now this is important too. So we also, not only the classic of the traditional cardiovascular risk diseases or factor, we take care of that, and as we mentioned before, diabetes, hypertension, but we also are working in a new emerging factor that now we know more and know that they play an important role in vascular diseases and death mortality in patients with this condition. One of them is psychosocial stress. So they trigger cardiovascular event, It's a huge risk factor, high prevalent, specifically in white Americans, and it's a barrier for medical intervention. So then this is data from, I think it was published in 2014, showing the depression is associated with an increased risk of death, either all cause, but also heart failure, myocardial infarction, or stroke, and also rehospitalization. So the patient, the most depressed is the patient, so the high risk of mortality. And we know that and there is data by us and others showing that the cardiac rehabilitation program have a significant effect in psychological stress parameter, including depression, anxiety, and hostility, regardless of the age. So there are significant improvement in these parameters. So knowing that depression is playing an important role in mortality after myocardial event, and knowing that the cardiac rehabilitation decrease this depression. So that is really another area that we need to focus. And what I want to mention, we discussed about that yesterday as well, that it's interesting that, this is a side comment, that the depression, we assess depression by PHQ-9 in all of our patients. And it's interesting that Hispanic American, so first or second generation, they, specifically from Mexico, they have a good PHQ-9, so they don't have so much anxiety, depression, compared to white Americans. So that's probably playing an important role, what we call the Hispanic paradox. So the Hispanic paradox in cardiovascular diseases mean that patients from Hispanic origin, when they have a myocardial infarction, the mortality associated with this is less than a white American that they have the myocardial infarction, and the data has been validated and correlated for other co-founders. So the analysis have shown that probably the reason is because this Hispanic population, they have a less depression. So this is will play an important role in this outcome, and also the social support, family support that they have comparing with the white Americans. So that is interesting data, a side comment. Sleep apnea screening. So this is important too, and we do this with all our patients. They have a Berlin questionnaire, a screening questionnaire to see the patient may be in a risk of sleep apnea, and if they are in a risk, so we do overnight oximetry in this patient. And the sleep apnea has been shown to be an independent risk factor for ischemic heart disease, other vascular disease, a stroke, and also increase all-cause mortality. So we can see that a patient with sleep apnea, they have an increase of number of death all-cause, and then death due to myocardial infarction, PTCA, stroke, and even non-fatal repetition of this condition or rehospitalization for this condition. And it's interesting that this individual with CPAP, if you can see in the curve, when you introduce the treatment for sleep apnea, so the data almost get close to control. So it's really, you can reverse that. So that is an important component on the cardiac rehabilitation program. And this is a meta-analysis showing that all combining the sleep apnea was associated with an increased risk of developing cardiovascular disease in this meta-analysis. So, smoking. I don't remember who published that, but the impact of, if by magic wand we eliminate tobacco from the planet, the impact in healthcare is huge. They think that it will be the same impact putting together the introduction of vaccine and the introduction of penicillin, antibiotics, the impact on life. So, wish we can do that. So tobacco is there. So tobacco is number one cause of many diseases, including cardiovascular. And you can see here the burden, the global burden of smoking. And physical activity too. If you see there, this is very interesting. The data is about smoking, but if you see the last in red or pink, you can see that the amount of death due to tobacco is It's a little bit lower than the amount of inactivity. So we were discussing about that yesterday, that sitting is the new smoking. So if you spend all day sitting, it doesn't matter if after sitting 8 hours seeing your patient, you go to the gym and kill yourself 2 hours, that 2 hours really will not produce so much significant effect in your health because you were 8 hours sitting during the day. And this 8 hour sitting have a similar negative effect in your body like if you were smoking. So now we're calling them sitting is the new smoking. So you have to be careful, just keep moving. I saw Pablo office that he has stand-up office, so that's we did with in our department too. We changed all the desk and it can be stand-up desk, so at least you're not sitting. So, but tobacco is an important thing, and we of course assess tobacco status, the patient, and do intervention. And it has been shown that really can be successful in this program because, again, 36 stations talking about tobacco, stop, and helping, giving the psychological support is really making more successful. And it has been shown that the strongest predictor of a smoking cessation 6 months after intervention, PCI, was participation in cardiac rehabilitation. So that was published in 2015. So again, it's giving us the tool or the fundament to say that what we do in cardiac rehabilitation really can be extrapolated to other primary secondary prevention programs for other disease. That's important too. Annual influenza vaccination, pneumococcal vaccination too. So all of our patients, we assess this status and be sure that they are up to all the immunization. There have been a strong correlation of mortality in patients that have vascular disease and then develop influenza. Now, this is, we talk about risk factor, physiological aspect of the cardiac rehab. What about mortality, rehospitalization, and patients that are involved or participate in cardiac rehab? Very strong data, and this is where the data that I'm going to show is coming more from Mayo Clinic, for the reason that I explained before. So this is the data about cardiac rehabilitation after PCI. So we analyzed those patients following for 10 years. And as you can see, 50%, so the death rate of 50% lower in patients that participate. So what other intervention do you think that can have this huge impact? What other intervention in medicine have this huge impact in mortality? We were talking yesterday that maybe, okay, forget antibiotic. I mean, we're talking about other, and forget the surgeon, eliminating surgeon, because they will say, one of the surgeon told me, well, if somebody have appendicitis and we intervene, it's 100% safe, or almost 100, okay, it's fine. I mean, forget surgery or other intervention for chronic conditions. So none that I know. So this is huge, it's 45%. And it can be persisted. So it's not only during the first year or a few months after you participate in the program, so this persists 10 years. What about in myocardial infarction? So again, we follow almost 3,000 patients for 10 years, and it shows a decrease of rehospitalization for all cause, 25%, for cardiovascular disease, 20%, and for non-cardiovascular disease, 28%. Actually, it helped for non-cardiovascular disease more than for cardiovascular disease, rehospitalization. So huge, again, impact. What about mortality after myocardial infarction? And again, so there is, as you can see in the curve, there is a significant difference of mortality in patients that participate in cardiac rehab compared with patients that they didn't. And this is not only myocardial infarction, PCI, but also when we do revascularization, bypass surgery, there is a 46% in decrease in all-cause mortality. All-cause, not only cardiovascular disease. So this is huge. And again, 10 years follow-up this patient. So it's important also that it's not only to go to cardiac rehab, so there is a dose curve response, so like a medication. So if you participate and complete the 36 session in the program, so the impact is much that if you only do 1 or 11 sessions. So nevertheless, one is better than none, but the idea is to try not only to refer this patient to the cardiac rehab, but to be sure that they complete the program. And I'm going to ask to the group and the residents that were with me yesterday, please do not answer, you know the answer, but what do you think that is the number one barrier for participation in cardiac rehabilitation? Knowing everything that we know, I mean, there is no doubt that every patient with cardiovascular condition should be eligible for this program. So what is the number one reason? Say it again? It's one of them, but it's the number one. No, it's not the number one. It's one of them, but it's not the number one. So we say transportation, social support, they are very important. They're like 2 or 3rd. Patient willingness is another, but it's not the number one. Who say referral? Referral. It's us. We don't tell the patient to go to cardiac rehab. It's the number one factor by cardiology, cardiovascular surgery. This is a shame, huh? So, but this is the number one. And you know how many patients eligible for cardiac rehab participate in the United States, in the whole United States? 23%. And everybody knows this data. I mean, the cardiologists and the cardiac surgeons know this data. And only 23% of patients participated, and the reason is because of referral. And then come transportation, I mean, social, economic, people have to go back to work. Women have less participation because of family issues, and African American also because of some of the socioeconomic issues. So, and Hispanic, of Asian, some of them because of language barrier. So, yeah, so there's many other. Transportation is number one, is one of the top 2, but the number one is referral. So, no excuse. Now, I want to talk about, this is an old data, but it's still very relevant. This was like one of the key studies that really changed the mentality in the area of cardiovascular disease, this COURAGE trial, where they showed that is a decrease when you do optimal medical therapy to treat cardiovascular condition, patients specifically with a stable angina, compared with intervention like PCI. Do you see the curve? There's no change. So we were doing PCI to every single patient that have an obstruction of coronary artery disease, even if they didn't have symptoms. We show that this doesn't. It's a percutaneous, the percutaneous intervention when you put a stent. Yeah, thank you. So when you put a stent to open the coronary artery, this is what we were selling our patients. So we have a patient with a little bit of chest pain when they exercise, but it's stable. When they exercise a level, not so much EKG changes, but it's an angina with non-coronary disease, boom, we put a stent. So showing that if we do focused therapy, optimization of the medical therapy, very intense, everything that we talked before, so the outcome are the same, and the cost, of course, much less. So that was a very key, and it has been a key trial that have changed the way that we work with chronic cardiovascular disease. So what about, this is important, people that participate in the cardiac rehab program, you saw the outcome, probably many of them is because they continue doing what we taught them to do. And there is data from our group showing also that there is a significant medication adherence in patients, even if we follow for 3 years, in a statin, aspirin, AC inhibitor, and beta blocker. It's not perfect. We would like to be 100%, but it's not so bad. And with patients that complete the entire program. And patients that complete the program after, again, 3 years, the risk factor control and goals are there, except in the BMI. And we had a nice discussion yesterday about that. Still the BMI, people don't lose as much weight as we expect. But what we have noticed is that maybe the weight is the same, but we have seen some change in the body composition, so the decrease of % of fat. Maybe they're developing a little bit more muscles, so that's the reason why the weight doesn't change. So, but that is the only one that we didn't see significant change as we expected. But the other, even some of them, the majority of them, they increase a little bit, they are better after 3 years compared to 1 year. So it really makes people to be compliant and adherent to the recommendation that we're giving. Financial issues, this is important, and it has shown from a financial point of view there is a highly cost-effective manner because reduced hospitalization, healthcare expenditure, and prolonged life and quality of life. And this is some of the data, how much dollar you can save, it costs, but also you saw the percent of decrease of rehospitalization, 46%, and the mortality. So, no doubt. Is saved, this is a good question, and I think that the resident, or somebody comment, I forgot who commented yesterday about no death here in the Johns Hopkins in cardiac rehabilitation program. We have one death in 45 years. It was a triple transplant patient that was participating there, unfortunately, but it's very safe. So basically, you expect one fatality every 83 years for a program that have an average 250 patients a year. So very safe, because sometimes people feel a little bit uncomfortable having a patient with heart failure or post-transplant or after MI, myocardial infarction, getting to the program 1 week, because the referral now, everything has been shortened, so they can start phase 2 program 1 week, 1 to 2 weeks after, and even surgical too. We take patients after are dismissed from the surgical team 1 or 2 weeks. So some modified exercise again, if they have sternotomies and for upper extremity, you need to be careful, lift, weight restriction, lifting, but they can start the program. Remember, the program has a component of education plus assessment of other risk factors, so you can start with that and introduce the exercise later. So, applying to other medical conditions, so we talk about cardiovascular disease. What about the medical condition? And look at this article, it's from 1976 and was published in the Archive of Physical Medicine Rehabilitation, already talking about thinking about the cardiac approach or medical approach for cardiac condition applied with a patient with amputee. What is the number one cause of amputation? So vascular. So we have the traumatic, but the majority is specifically for lower extremity. So patients with diabetes, vasculopathy induced by diabetes. So they have, if they already have an amputation, it means that they don't have a vascular disease in only one artery. So you have to assume that it's generalized. So that is in 76 already talking about that. But this is one that was published in November of this year, 19. Our colleagues, Dr. Kugrulo from JFK Johnson Rehabilitation Center, and a very nice study where they took stroke survivors and they introduced a modified cardiac rehabilitation program to them, and they showed that it's a reduction in all-cause mortality, and they improved the cardiovascular performance and functional performance. And this is some of the data from this publication, and I will really recommend it to read it. This is very, very well done and written. And there is a progression of a MET on those individuals that participate. Those are stroke individuals that participate in this cardiac rehab program. And again, it's a dose response too. So the most that they do, the improvement in MET on this patient. Also, there was an increased survival. I mean, it was not so long. I mean, they did a study for 400 days, but in 400 days, you can see there is a significant difference in survival on the patient that participate in this cardiac rehabilitation program, modified cardiac program, or using cardiac rehabilitation principle to stroke, let's put it that way. And also not only in death or cardiovascular thing, but another thing that we are very passionate about that, so quality of life. So the patient, as you can see, they have a improvement in motility, in the daily activities, and overall quality of life, and cognitive too. So positive impact in this study. So now their plan is to try to see if we can do a multi-center study, and we have a conversation with yesterday, so we were talking about the possibility maybe to connect with Sarah as she tried to explore that and be probably Johns Hopkins as well as Mayo Clinic to be part of this study. I think it's very exciting. It's very exciting. Stroke is a vascular disease, so it makes sense, completely sense. What about spinal cord injury or cardiovascular disease? So there is a lot of change. This is an area that have not been studied so much, and we have been very successful in keeping our spinal cord injury patient alive for a long time before they didn't survive 10, 15 years now. They have almost a normal life expectancy. So they are developing cardiovascular diseases. But there is not so much study about that. And this is a different population because we still don't know if some of his cardiovascular diseases that they develop is because all the risk factors that we know that they have, or is due also to the physiological change that the cardiovascular system have, specifically in a high lesion patient like a quadriplegic. So we know there is a significant change in the physiology and control, specific autonomic control of the cardiovascular system. So we don't know. But we know that during the chronic stage, cardiometabolic and cardiovascular disease risk factors become more prevalent in this patient, and it's estimated that 30 to 50% of individuals with chronic spinal cord injury, they have already cardiovascular disease. And risk factor, physical inactivity, we know how important a role play. They have also low high density lipoprotein because this is associated to physical activity. They develop type 2 diabetes again because of the physical inactivity. Hypertension, the visceral adiposity, we know that the fat on the tummy is more dangerous for the heart than the fat in your legs or in your buttocks. So that is another thing that we are learning, that not all the fat tissue are the same. And our patients with spinal cord injury, they develop more visceral abdominal adiposity. And they have a lot of elevated inflammatory pro-atherogenic. They have high CRP protein as well. So many risk factors. And this is interesting that, I don't know if you are familiar with the spinal cord injury rehabilitation care high performance indicator or HIGH project. So it's a program that was developed to implement and evaluate consensus-derived quality of care indicator for some domain specifically related to rehabilitation in patients with spinal cord injuries. So, and one of them, this was just published, is to develop a cardiometabolic health indicator to advance the quality of spinal cord injury rehabilitation. So you have the opportunity to read the article. I will recommend it. Give us a lot of tools that we can use to assess this patient during the acute inpatient rehabilitation as we follow in our own life, and then give us opportunity also for research to try to understand what is the right intervention that we can do with this population of patient. So the Continuum, there's a Continuum cardiovascular care. We talk about personal lifestyle, public health, community intervention, primary prevention aspect. Then sometimes our patients have the disease and they end in cardiac rehabilitation. This is the current model. And then they continue with secondary prevention. But as we saw, these cardiac rehabilitation paradigms and program and goals and what we are doing on those programs really can, those principles can apply to primary and secondary prevention of any other disease, to continue of care in our rehabilitation program. Why? Because lifestyle modification are key. Smoke cessation, diet, exercise, activity, weight control, and this we do in this program. Those are the principles: the lipid management, blood pressure control, exercise tolerance, psychological well-being, stress management, or maximizing medical treatment of comorbidities, and return to work and increase quality of life or improve the quality of life. So all of these principles, as you can see, can be applied to any of the aspects of the rehabilitation medicine that we do. So with this, I want to thank you again for giving me the opportunity to be here. I really have enjoyed a lot, so thank you. And any questions? And I hope you understood the accent. So. Yeah, any question that you have?
It's a big room, but you can yell.
Yeah. Mm-hmm. Yeah, it's a good question, and as you see, we are not able to completely eliminate the mortality. So still there's some mortality, and probably because the patient that fails, a patient that they don't have a right nutrition and they no weight control. It could be, so we don't know, but we have not studied that. That's true. It's very difficult. So nutrition is very difficult to control. You tell the patient, you ask the patient when they come to the consult. We follow this patient after they are dismissed by phone call or face-to-face, 3, 6, 9, and 12 months, and we ask about diet. So we trust what they said when they say that they are following the diet, but yeah, we don't know. Now with the BMI, we are not following, this is the parameters that the outcome that are officially people follow for research purpose, but we are focusing more in body fat composition. And I didn't bring this data, but we have seen significant body fat, not so much in body weight as I mentioned, but body fat composition, decreasing that with people that do the exercise and then continue. So we are getting a little bit away of a BMI, although a healthy weight is the best, but it's more about what do you have. We have many individuals, and I didn't bring this data, maybe next time we can share about that, but we have published data associated with people. We have a good group of individuals with normal BMI, and they have high fat composition, so we call obese with normal weight obesity, and we put them in the category of obesity, and their risk factor are, the risk to get cardiovascular disease in 10 years are as high than people with a high BMI, and less than people with high BMI and lower body fat composition. So we're getting more into that area as well. We have it. Yeah, we have a nutrition. So every single patient get an appointment with a nutrition, and we have a lot of education and classes about how to read the label, how to understand, to go and shop and buy the right food, and also how to identify the food that is healthy and is not so expensive. Because if you go to a supermarket and you try to eat vegetable and fruit, it's very expensive. So how you can eat healthy, not so expensive, and how you can understand, because it's not only the fat or sugar, also salt. So how you can read the label of the food. So with that, we have a nutritionist, and they also, in our program, they get classes, cooking classes. There is a chef that go once a week, and it's on Wednesday, and they cook. We have a kitchen in the rehabilitation program. I should have put some picture about our gym and area. But they had classes by a chef, and they learn how to cook healthy food, tasty, because the concept is that everything that is healthy doesn't taste good. No, so there is a nice food that they are healthy and tasteful. So we do that in that aspect. And the area where they exercise, all is full of posters showing the equivalent. For example, a can of Coca-Cola, how much is on sugar. So there's a picture of the can of Coca-Cola, and also a glass with how much sugar have this Coca-Cola. It's like a half of the glass Coca-Cola. The same thing with fry. We talk about that. Fry, how much fat. We have a tube where it shows how much fat contain a package of fries from McDonald's, for example. So people, when they see this visual, they get impacted. There is a book also called Picture Your Perfect Diet, and we use that book a lot. It's just picture of food and what is the equivalent, and a picture of salt or sugar or fat, and it's really, even myself, I don't eat pizza anymore. I got so like, what? A triangle of pieces like this of fat, and no way, so. Any other questions? Yes, I'm sorry, Peter.
Carmen, this is a really exciting talk. So formal cardiac rehab programs are not always available everywhere, but we can still incorporate the same principles because we see these patients, all the time. Do you have any recommendations for how we could use these principles when incorporated into, our regular therapy schedules, our regular sort of appointments with our patients? Do you have any pointers for that? Clearly, there's
Yeah. So we had this question was, I think, when some of the residents asked that question too. So what we are doing, and not so much in our, in the prevention clinic, the question is how we can incorporate some of the principles that we talk in our daily activity when I see a patient in the consult service, no specifically a cardiac patient. That's the question, so how we can do that. So what we have done in some area in the preventive clinic is we have an exercise physiology and we have a nutritionist on floor. So when we detect an individual that will benefit to have a consult about activity, exercise, and also nutrition, so we ask, they are sitting there, ask for them to visit and to give the education and share material and video and access, resources. So it's free, so we absorb the time. So what we're doing is some of the exercise physiology that work in the cardiac rehab, there is a schedule, so we borrow them and bring them to the floor. So let's say you are in charge on Monday, you are coming on Tuesday, so they are on the floor waiting, and we use them. So we get out of the room and said, stay in the room. One of my colleagues is going to talk with you about exercise and nutrition, and they step in and talk with that. So it's an extra cost, but at the end, from financial point of view, when we did our analysis and it helped, and the patient liked it too. So that's some of the things. We ask smoking to all the patients, and if they're smoking, we offer to an appointment with our smoke cessation clinic. So we do that as well in terms of smoking. And it doesn't take so much that, 5 minutes that you give a glance of the glucose level, the blood pressure. We take the blood pressure of our patient when they get there, and we ask about that. So it had to be an extra 2 or 3 minutes that you have to put in your mind to assess those risk factors. But specifically smoking, nutrition, and activities, we assessed it, and we have that tool on the floor. The cardiac regeneration? Yeah. I will be happy to do that. So I'm part of the team that's working with using RegenMed, cardiac regeneration, regenerate the heart, or after myocardial infarction using stem or cell therapy, we call that. So we started in 2000, it was the first paper published showing that in animal models it may help. So since then they have been, we and others have done, there's a lot of research working in that area. As you know, it's a #1 cause of death. So there's a lot of resources invested on that. So it's interesting. So we were talking about how the field have progressed. So initially you were injecting this stem cell in animals, embryonic stem cell in mice, that we induce a myocardial infarction by ligating the coronary artery. And then we do open heart and inject around the infarct area the stem cell. And those animals respond so nicely, improvement in the cardiac function by measuring with the ejection fraction. And also, when we did the histology, you could see that the area of infarct really regenerates. So it was much better, and there was neovascularization. Interesting, when we were injecting more than 3 million of cells, those animals developed teratoma. So it means that there was a dose less than 3 million that we needed to use. Otherwise, these embryonic stem cells were injected and they just differentiate whatever they want and without any control. So the heart, the environment of the heart could not control those cells to make them to differentiate into cardiomyocyte. So this progressed to test it in humans. So taking a stem cell, we cannot use embryonic for issues that including ethical issues. So we were injecting a stem cell coming from the bone marrow, so hematopoietic stem cell or adult stem cell. So what we saw was very interesting that some patients respond well. There was some increase in the ejection fraction, but some of them no. So when you put together the result of the trial, the changes are none or 3 or 4% of the ejection fraction. Well, guess, if the patient participates in cardiac rehab, you have an increase of ejection fraction by 10%. So I was telling the scientists, the group, we are doing this procedure, just still rehabilitation, cardiac rehabilitation much better. So what we did is taking those cells, the patient that did in no response, by the way, those are patients with a chronic They have a myocardial infarction, and now they have a cardiovascular disease, chronic cardiovascular disease induced by that. So there was no acute myocardial infarction. So we took those patients that they didn't respond, we took the stem cell and we brought it in vitro and realized that those cells in vitro, they didn't differentiate into cardiomyocyte. And they have a genetic background and expression of factor background that was different to the cells of the patient that did respond. The patient that did respond, we took the cell and the cell were able to differentiate into cardiomyocyte. So we have individuals that we applying the same treatment, different response, because some of your cells, the stem cell of this individual didn't work, the stem cell of this individual worked, which is not surprising because we know that we are all different, that we respond different to medications, so it was not surprising that we respond different to this intervention as well. So what we need as a next step was taking those cells, taking now, instead of injecting a stem cell coming from the bone marrow to all patients, we're taking these cells and we are pre-treating this cell in vitro with something that we call cardiogenic cocktail. And the cardiogenic cocktail is a mix of transcription factors that we know by just studying embryogenesis, that those factors are released by the endoderm, go to the mesoderm, and activated the cardiogenesis in 3.5, 4, 5 days post-fertilization. So we took those transcription factors, put it in a Petri dish with the cells, and then we allowed the cell to start the process of differentiation to cardiomyocyte. And when those cells were already expressing some of the early genes of cardiac cell, we took this cell, and those were the cells that we injected now in the heart of individual myocardial infarction. And then we saw significant improvement of ejection fraction in all of them. So that was very surprising, very rewarding. So, but knowing that we need to tell probably the cell, okay, you are going to be hard. Just don't go there and just die. You're going to be hard. So teaching them. And then what we, I forgot what I want to say, but oh yeah. But there was something when, yeah, this is important, but I forgot what I want to say. Well, but we injected these cells so the patient respond, improve the ejection fraction, and also improve the 6-minute walking test on this patient. So it was very safe. So, I remember what I want to say, that the other thing that we realized, that was the first study, safety, was very safe, 300. Then we did another one, now more randomized, double blind, and we realized that the patients that respond to this treatment were patients that have moderate heart failure. So patients that have little heart failure, not so, ejection fraction is not normal, but not so bad. They didn't respond to this therapy. There was no more improvement. Patients that have severe heart failure with the ejection fraction of less than 20, the patient didn't respond either. It was the 30-40%, the ejection fraction 30-40% that they respond well. So moderate heart failure, which also have been seen in colleagues that have injecting PRP or they're injecting BMAC. On joints diseases like knee joint arthritis, so they also see that if it's too advanced, if the arthritis is too advanced, they don't see any response to platelet-rich plasma, so similar that. And you say that? Oh yeah, so the other thing that we saw is that this cardioprojectic cell, so we call this, so there were two new concepts that we developed, which is the cardiogenic cocktail. And then the other thing was the cardiopoietic cells. So instead of hematopoietic cells, so we are injecting cells that are not full cardiac cells, they are not stem cells, so they are cardiopoietic cells, or cardiopoietic stem cells. So we then said, this is just an artificial cell that we are creating in vitro, or that really exists in the nature. So what we did is that analyzing in animals, and we found that they have some level of these cells circulating in the blood, but also human. That was very interesting. And what we did in our cardiac rehabilitation program is analyzing, we were able to the clinic were calling us, there is a patient with MI, so we were immediately and take blood and analyze the number of these circulating cell. And then when the patient participates in the cardiac rehab, we follow these 3, 6 months, 1 year. And what we see, there is an increment of circulation stem cell, and this increment is associated with improvement in the ejection fraction. So it was a few number of individuals, but we see significant association. So we are planning now to do more study about that, but it was very interesting. What did that mean? It was just a correlation study. I mean, we don't know if it's a reaction to the body to heal or just, yeah, or it was induced by the exercise, so we don't know now. We need to understand more. But it was very interesting data. So we have cardiopoietic cells circulating. And we were talking yesterday, Pablo and the group, that when I studied medicine, we were told that the heart does not regenerate, the liver does not regenerate, the brain, and now we know that they have the potential, and all of these organs have a stem cell, resident stem cell. Now we need to understand how we can potentiate those cells, so really giving the tool to individual to heal by themselves, inner healing. So, thank you. Thank you.
Posters and food is going to be outside in the hallway.
Thank you.
Good job.
Hope that you